Our next speaker will be virtual. So I'm going to have the pleasure to introduce Dr. Jacob Sands, the thoracic oncologist at Dana-Farber Institute.
Hello. Thank you so much. All right, so let me grab my slides. Okay. I am sorry to not be in the room with you. I know I gave a remote talk to this group months ago, and it was such a wonderful experience. I wanted to join you again. And someday I do look forward to being with you all in person. I could feel this is a special group through the screen in that last discussion. So I really look forward to your comments and any questions. I know it complicates things a little bit by the fact that I'm joining remotely, but hopefully we can still have a discussion. Okay, so wow, this is really fantastic because I can see that you can see my screen. Clearly the crew that's running your AV is exceptional. So I want to start out with some initial points. First of all, we have made a lot of progress, and we know it's not enough. I'm going to highlight the fact that I believe we're actually curing some people of their incurable small cell lung cancer, and that is a huge statement, and it is clearly not enough people. It's unfortunately at this point still small in percentages as far as the numbers, but the fact that that's happening at all really makes me optimistic that we're finding ways to not only improve survival, but actually dramatically improve survival. And so this is something that is happening enough, but for not enough people, if that makes sense. Now, the other thing is that progress is exciting to see. And the fact that we have any cases at all to really highlight as exceptional and where we are getting enough out of the treatment, it's not enough in those in the population total. And those of us that work in small cell lung cancer and work to advance new treatments and develop new treatments, we know it's not enough. And although I am going to highlight some aspects to celebrate, what keeps me awake at night is the many more cases where we need something like that, but don't yet have it. So although I'm going to highlight some things we're excited about and some real advances in the field, I want you to know that underneath that, there's much more of a sense of urgency about the fact that not everyone is getting some of these advances that we're seeing. But to start out with what's possible, this is a woman that I saw, 70-year-old, was diagnosed with extensive stage small cell lung cancer, had multiple sites of disease. This is a PET scan. And so on a PET scan, it has a tracer that lights up to areas where we see, lights up to areas that pull in glucose. Glucose is something that all the cells of our body utilize, and cancer cells, just like all other cells, utilize it. Cancer cells tend to be far more active and therefore pull up more. But this was in May of 2019. And this is the heart. Let's see. Can you see? Hopefully you can see my pointer, but I trust you can. Let me know if you can. This is the heart. That's normal. This is the left kidney because this person is facing us on the scan. Left kidney, right kidney, and bladder. Those are all normal to light up. But everything else is disease. This is small cell lung cancer throughout the chest. You can see there are multiple sites, also multiple sites throughout nodes and bone within the abdomen pelvis. So this is extensive stage. On top of this, an MRI of the brain showed some brain metastases. She got radiation to those spots in the brain and then started carboplatin etoposide and atezolizumab, so one of our checkpoint inhibitors, as we say, immunotherapy. And she started that in April. So you can see that this PET scan was shortly after having started the treatment. And this is her scan in September. So 4 months later, you can see that the disease is essentially gone on scan. Now, when we say that this is what we would call a complete response, and this is largely likely from the chemo, but we can't say. Would the immunotherapy alone have done this? Seems less likely, but there's no way to know for sure. Now, the unusual thing about her case, and I say unusual, but she's not the only one I've seen this on, is that I have not given her any more treatment aside from these first three drugs. Now, she got chemo and immunotherapy, the atezolizumab being immunotherapy. She got that, and she continued the atezolizumab for a little bit more than 3 years, around 3 years. So until early, about a year ago, actually a little less than that. So a little less than 3 years, she had gotten the immunotherapy. Oh, sorry, I have the year here wrong. The year when started, I have that year wrong. So it's been a little more than a year since she's gotten any systemic treatment. She did have spots in the brain, new metastases in the brain that showed up while on this treatment, but everything on her CAT scans continued to look good. And those spots in the brain were treated with radiation. She had that 3 more times, but nothing else that showed up on CAT scans. And at this point, it's been more than a year since she's gotten any treatment. Now, is this something that will show up again? It certainly can. I do have some other patients who are now more than 3 years out from having stopped their immunotherapy and more than 6 years out from when they were first diagnosed. So these are the outlier kinds of scenarios that we get very, very excited about, because this is, of course, overwhelmingly positive for each of these individuals. But as I said, the real effort here is how do we get this kind of a response to treatment for everybody? And that's where there's still a lot of work to do. Now, I often get asked by companies in particular, where they say, okay, we've got this trial that we're running. What kind of outcome would be the most meaningful? What is the outcome that would make you decide that this is or should be the new standard of care? And I've always found that to be something that I'd be explaining a lot of stuff. And so I developed this figure to help explain it better, is that there is no one factor that is the thing that would make the drug the thing to use. And I'm presenting this here really more so that you all can advise me on how you think I can improve this figure. So let me explain it. There are 6 criteria here, or 6 factors to evaluate: the response rate, what percentage of patients experience a significant reduction in the size of the tumors. 2 is the progression-free survival, the duration of time that the treatment works. And this is typically reported in the median duration, meaning that half of patients experienced that amount of disease control or better. Overall survival, how long people live for when they've gotten that treatment. Again, that's in median. 50% of people have experienced that or better. As far as toxicities, the side effect of the drug, the schedule, how frequently you have to come in. Of course, if it was an everyday infusion, that's going to be a bigger issue on people's lives than if it was a treatment every 6 to 12 weeks. And the cost to the patient. Now, cost, if your insurance covers the full cost, I think this is we're at a point in the US where certainly this is an important discussion around like cost to the healthcare system and such. But I'll tell you very frankly, I don't care at all about the cost to the healthcare system when I'm taking care of an individual. But I do care about what the cost is to them. And so when people have a copay that is an extraordinary sum of money that really makes it not feasible or is going to bankrupt these individuals to try to continue these treatments, that's a really important thing for the oncologist to know about, to try to find ways to reduce that. There are programs that can help with things. And so as an aside, I just encourage anyone that if something is really a lot of a cost, to be very open in discussing that. Nobody is going to just stop something or decide that you shouldn't be getting it for whatever reason, but it gives them an opportunity to find ways where there are certain programs or something that might help cover that. But those real costs to an individual are something that play a factor into, I'd say, the toxicity of the drug itself. And then the other factor here, the DOR, is duration of response. That is, when the drug works, how long does it work for? So overall survival, how long people live, response rate, the toxicity of the drug, the duration that the drug works when it works, the dosing schedule, how frequently people have to go in, and how long the disease is controlled. So those are the 6 factors, and I welcome any thoughts about what else I should be added or any other suggestion around that. But just to show you, so first line carboplatin etoposide. So this is chemotherapy alone for small cell lung cancer when it's first diagnosed. Tends to work in the majority of people, and in many people actually rapidly shrinks the amount of the disease. And so I'll tell you, I mean, my scoring on this is not meant to be to great detail, but more as a demonstration of this figure. So the response rate I ranked a 4 out of 5. So starting at 0 out to a 4, I ranked it at there. How long people live and for how long the drug works. Unfortunately, the drug does not work an extraordinary amount of time for the majority of people. It works great, but then the cancer grows. And so I ranked that not particularly well, because there's a lot of room for improvement. As far as the dosing schedule, it's every 3 weeks. It is 3 days in a row. And so I ranked it as such. How long it works for is where I said this is clearly not enough, because in most cases it works for months, not years. As far as the toxicity, it's toxic and people lose their hair. Thankfully, a lot of the nausea was very, very common about 20 years ago. The meds we have for nausea have drastically improved that, although it's not gone. But for most people, it's not nearly the issue it used to be. But it's a toxic regimen, so I ranked it in this way. So this is the overall shape of this, and it again highlights that there's a lot of room for improvement. We need to do better. When adding in the immunotherapy, like in the case I just demonstrated, the response rate is similar. The duration of response, when it works, is really quite a bit better. And we see now a number of patients that have ongoing disease control for years, which is not typical from just the chemotherapy. So it doesn't add a tremendous amount to the other stuff. The median, meaning the 50% and more people, how long people live, how long disease controlled, and such, is similar. But it's that those who have a response to this immunotherapy when it works is really extraordinary, and I'd say revolutionary. I mean, really changes lives pretty drastically for individuals that benefit from the drug. Unfortunately, not enough people benefit from this drug. And related to that, these are the curves that we look at, and so in the publications, and you'll see that these curves really go down together. Again, not enough. We need to get to the point where from the beginning we have a straight line across, meaning that everybody has disease control from the start. And what we've seen from these drugs is, in this tail, we're having a number of people that are still benefiting from this. And you see that in both of these trials. So a subset of individuals that I'd say some of whom are potentially cured of this incurable diagnosis. I'm going to highlight a couple other things before we move on, and this is NCCN guidelines. The NCCN is a group of experts in the field that come together and essentially create a flow chart of sorts, but there's a lot more information than just a flow chart, but of the recommendations for which treatments are recommended and which treatments are reasonable to use. And I have patients from time to time that come in who have gotten their first line chemotherapy and immunotherapy, and then they maybe got one or two other treatments after that. And then their oncologist, or they tell me that their oncologist told them that there are no other treatments. And so they come to me as this last ditch looking for anything. And in some cases, I'll point out, well, there are multiple other commonly used drugs that you could still get with your local oncologist, or I'm happy to treat them here. On top of clinical trials. And after this part, I'm going to really highlight some of what's going on in the clinical trials, because that is very important to know about. There's more going on right now in small cell lung cancer treatment in trials than I'd say the culmination of everything that's been done before. As far as the kinds of treatments in trials that I think likely have a legitimate place in the future standard of care, which happens after being demonstrated in the trials. But that being said, so first, just what's available. Now, we talk about a chemotherapy-free interval of greater than 6 months or less than 6 months. That's when people get that chemotherapy plus immunotherapy from the time that they finish that chemotherapy to when the cancer grows again. That's that chemotherapy-free interval. So people are still on the immunotherapy, but it's what is that duration of time? I'm not going to focus too much on the specifics around that, other than just highlighting some of the drugs that are still available. Lurbinectedin was FDA approved and an accelerated approval about 4 years ago now. It was in 2020. Topotecan, irinotecan, topotecan by pill or IV was the longer standing FDA approval. Those are the two drugs now that have an FDA approval. But that being said, we very commonly utilize irinotecan, paclitaxel. Temozolomide is a pill that also works very well in the brain. And so these drugs are all what I'd call standard of care, even though I've highlighted just two of them are officially FDA approved. These other ones are older drugs and commonly used. The other thing I'm highlighting here, more so even, is clinical trial enrollment. And we'll go over some of what's happening currently in small cell lung cancer treatment. The other thing is nivolumab or pembrolizumab are on here. These are Opdivo and Keytruda. Those are just the other brand names for the drugs, but sometimes people recognize the brand names more so. And these previously had an accelerated approval. Their first-line trials did not meet their endpoints that were predefined in the trial. And I'm happy to answer any questions around that, but these are drugs that I see as very beneficial in individuals that never got a checkpoint inhibitor before. So, so if somebody had limited stage, meaning they got treated with chemo and radiation, but then the cancer showed up again, those individuals would not have gotten a checkpoint inhibitor previously. And I do think it's important to then consider whether this is an option. Now, I didn't put a slide in for this, but I should mention there was a press release. We haven't yet seen the data, but there was a trial now in limited stage with chemo and radiation that also incorporated a checkpoint inhibitor that showed a positive outcome. It met its endpoint. And I'm very much looking forward to seeing the details from that. And I fully expect that that will ultimately become FDA approved as well, which would make this scenario that I just described not, but far less common, where when patients get chemo and radiation, they would be getting a checkpoint inhibitor. Therefore, going forward, we'll see less and less of the scenario that I've described. But I am going to highlight this is just pembrolizumab alone, and you'll see, as I described, for the majority of people, the drug ends up not working, and that is distressing. And this is where we need to find ways to get the benefits of this drug for more people. But the real benefit of this drug is what you're seeing on the right side of this curve, in that although it shrank the cancer, it significantly shrank the cancer in only 19% of individuals. It worked for more than 2 years in more than half of those people. So when the drug works, the potential there is really extraordinary. Unfortunately, it works in just a subset of people. So now we're going to focus a bit on the road ahead, which frankly, when I say road ahead, that's in what trials or what drugs may end up being FDA-approved options in the future, but these are available currently in clinical trials, and these are the things that I'm optimistic about. Before I get into that, though, just the diagnosis of small cell lung cancer itself, there is now a proposed subtyping. So rather than saying that this is just small cell lung cancer, we may at some point, and it's still too early to do this, is say it's small cell lung cancer and such subtype. Much like in non-small cell lung cancer, we have the subtype adenocarcinoma, we have the subtype squamous cell carcinoma. This may end up being a small cell lung cancer subtyping. There's more work to do in this. This is from the initial publication, and shortly thereafter, another publication had very similar subtyping. And I'm happy to answer some of the details of that, but I'll leave it that broad for the moment. Right now, this does not impact our clinical decision making because we haven't yet defined with a certain subtype, there's some treatment that works in everybody, or within a certain subtype, there's treatment that doesn't work in anybody. But this is just the beginning of evaluating those subtypes. This is looking at in immunotherapy, the incorporation of immunotherapy and the long-term, the patients in which the immunotherapy worked for a long time. And you can see that it was a little more than 50% of people that had long-term disease control with the incorporation of the immunotherapy. In the group that got placebo, there were still some, but the number of that percentage was smaller. So it seems to make it more likely that people will have that response to the immunotherapy. In the other subgroups, we did not see that kind of long-term disease control to the same degree. So is this meaningful with this certain subtype? Maybe, but I wouldn't hold the immunotherapy for all the other subtypes either, because there are some people that still get long-term control from the incorporation of that immunotherapy. This may be more meaningful to some of the drugs that we have in clinical trials, and so there's ongoing work in that. Another biomarker, something called Schlafen-11. This was a trial in the first-line setting. There's some suggestion that Schlafen-11 might matter for tumors with the incorporation of a PARP inhibitor and getting better outcomes and better efficacy from where that drug works better in individuals that have a tumor that's Schlafen-11 positive. And so this was a trial that enrolled patients with Schlafen-11 positive tumor, small cell, and it enrolled. Now, the outcomes of it, I don't think changed the standard of care, but it was a demonstration that for small cell lung cancer, we can do these biomarker-driven studies. And I think this is a good way of demonstrating that it's worth us enrolling these trials where it seems to be potentially indicative of who's going to benefit most, that this is feasible. I'm going to go into some of the current trials. Lurbinectedin, I've mentioned as a drug that got accelerated approval. I think when I do that figure that I showed in the very beginning of how I would rank a drug or how I would define a drug, lurbinectedin is a little bit better than the other chemotherapy agents in multiple arenas or multiple of those points on the hexagon. And so I think it represents a real improvement if we were to look at the size of shapes. But that being said, it's a step forward. We're not seeing people that are getting years of control from this drug alone in the same way that we're seeing from the immunotherapy. But I do think we're seeing more people that benefit from the drug than what we see just from the immunotherapy. So is a combination of these. Will we see synergy, meaning that the way that the lurbinectedin works and the way that the immunotherapy works, will the lurbinectedin help get that immunotherapy effect for more patients? Possibly. And so this is the premise of this first line trial, which is adding lurbinectedin to the maintenance setting So people get their chemo plus atezolizumab, and then in maintenance, either get lurbinectedin plus atezolizumab or just the atezolizumab, which is the current standard of care. I mean, atezolizumab or durvalumab are standard of care. In this trial, atezolizumab is what's used. This is another trial where people have had the cancer has been growing after that first line treatment. And so this is lurbinectedin, which is a standard of care, or topotecan or irinotecan, which are both a standard of care, or the combination of the two to again see, can we get synergy from those two drugs together? This is the kind of trial that if it's a long drive to get to the academic center, this might not be the most appealing, given that there's a 2 out of 3 chance that you'd be getting what you could get with your local oncologist. But I'm hopeful that we'll see real benefit from this combination. There is a prior study that showed surprisingly good outcomes, meaning that much better than what we would expect from just lurbinectedin alone or just irinotecan alone from that combination. And so hopefully that's something that we'll see within this trial. Getting into some of the more novel, newer studies, tarlatamab, this was something that, okay. So tarlatamab, actually, I'm just going to go to this one. This is a bispecific T-cell engager. So essentially, this is a compound you see here on the left that binds to the tumor cells on DLL3 receptor and binds on the T cells on a CD3 receptor. So pulls them together, essentially creating an immune response. So like the immunotherapy I described in the first line setting, this is not a toxin. Chemotherapy is a toxin. Chemotherapy is a drug that essentially disrupts very actively growing and dividing cells, disrupts them enough that it kills them. This ends up helping the immune system to have the effect on the cancer cells. So the cancer cells aren't killed by the drug itself, but by the immune system, which is facilitated by the drug. And you'll see that in this trial, this was presented in October at the big European Oncology Conference and published in the New England Journal. And this is what's called a swimmer's plot here on the top right. This is each of this is an individual that's on the study. And those that have the arrows on the end are ongoing still on the drug at the time of this data collection. And you'll see right here, here's 50. So this is about a year out to here. And what we've seen from this is that there was a good number of patients, not enough, but a good number of patients that had a response to the treatment. And those who had a response, many of them had ongoing responses. And so that duration of response, we don't yet know that because there were enough people still benefiting from the drug that that we don't yet have a sense of what is the point at which 50% of the patients and more were still benefiting from the drug. That's still being followed. And so we'll see how long that goes for. But this has been very encouraging to see such long-term responders in the third line setting. So these are people who had gotten 2 prior treatments, two different regimens of treatments. Now in this study, they looked at 10 milligrams and 100 milligrams. Really 10 milligrams is what will be going forward. As far as side effects, this was mostly what's called cytokine release syndrome side effects, meaning that people in most cases got a fever, took some Tylenol, and were better. In some cases, people had a little bit of a drop in their oxygen level or a little bit of a drop in their blood pressure and got IV fluids or got oxygen. And you can see that this is on the top here is the 10 milligram group. So that's what matters going forward because that's the dosing of the drug that I expect to be pursued. In cytokine release syndrome, 40% of patients. So this is common. But as I said, in many of those, it was just a fever. Some of those had a little bit, needed IV fluids or some oxygen. And you see that it was 40% with that first dose, 28% with the second dose, which was a week later, and then really far fewer. Needing something more significant than just the IV fluids or oxygen, there was one individual that had more severe symptoms from that. Now, that is a representation of the immune system being kicked up. So in some ways, this is a side effect of what we want. We want the immune system kicked up. We don't want it to be causing some of these other symptoms, but we want it to be kicked up. And this is a drug that I fully expect to end up being FDA approved at some point this year. These outcomes are, I'd say, are really impressive, and hopefully that duration that we end up ultimately defining will be really, the further out that goes, the better. And so the longer it takes for us to even find out that number, the better, because that means the longer it's taking and the number of people that are still benefiting from the drug is more than 50% of the individuals that had a response to treatment. The other thing on here is what's called ICANS, and that is neurologic. That can be some confusion, and there are other things that go along with that, but I'll broadly say confusion. And thankfully, that's pretty low numbers. That also is something that typically improves, just like the cytokine release syndrome. And those are the side effects to be most aware of. Now, if this does end up being FDA approved this year, these are the types of things that the oncology teams are going to have to quickly learn about if they didn't participate in these trials, to be able to offer it as an FDA approved standard of care. Tarlatamab is not the only one in this class, and here's a drug called HPN 328. This is same thing, DLL3, CD3, so binds to the tumor cell, binds to the immune system. It also binds albumin, which is a protein in the blood. It just as a stabilizer, and this is a drug that's enrolling for small cell lung cancer as well as other tumors. And so that swimmer's plot that I showed you before, this is fewer numbers. This was presented at ASCO a couple years ago, but we see multiple with ongoing responses, and I've seen some very good outcomes on this drug as well. Here's another one. This is a Boehringer Ingelheim drug that is currently still in trial. Same thing, you see CD3 on T cells, DLL3 on cancer cells, links them together, creating a response, an immune response. This is what's called a waterfall plot. Down is better. This is reduction in tumor size. And so you see there are a number of people that have their cancers shrinking when on the treatment. And this is looking at small cell lung cancer, as well as neuroendocrine carcinomas and large cell neuroendocrine cancer. So other tumor types. I think the benefits of these drugs likely go beyond small cell lung cancer, but speaking specifically about small cell, I expect this whole class to end up being an important part of the treatment paradigm. Now, related to DLL3, this is CAR T. So this is where we essentially, so when people go in and donate blood, or maybe better to say when they donate platelets, blood gets pulled out into a machine, they spin it down, and they pull off that platelet level and then often give people their blood back. In this case, we spin their blood, and then so that it layers out the different blood cells, and then we pull off the white blood cell layer, the immune system layer, and then give people back the blood, the rest of the blood that was taken out. Those immune cells we then process to specifically identify the receptor DLL3. This is a very common receptor on small cell lung cancer that is not on other cell types for the most part. And so we then, it's their own immune cells that essentially now have been trained to find DLL3 receptors and kill those cells. So we pull out those cells, we process them, and then it's weeks or even a couple months later, infuse those cells back into their body so that this now entrenches as their new immune system. It is their old immune system, but just trained to also seek out DLL3. So that entrenches back in the marrow and then becomes a cancer-seeking immune system. This is very early. This trial, this DLL3 CAR-T trial with a Legend Bio drug is just accruing this year, so still very, very early. Another one is DLL3 and CD47. This is another type of a receptor that impacts immune function. This is a receptor that essentially tells the immune system, we call it a "don't eat me" receptor, saying, "Hey, relax, don't kill me." And when we when we bind that along with the DLL3 together, we can actually create then more of an immune response so that the immune system clears those cancer cells. And so this is a trial that's also ongoing. You're seeing a trend here with DLL3 because we've identified DLL3 as being an important receptor for small cell lung cancer. Here's another very early concept, but something that has been demonstrated using a PET scan that binds to DLL3 to be able to see how much DLL3 expression is there and where. And then this is using essentially radiation to then be able to infuse, to bind to that receptor, to then radiate that area. And so these radiopharmaceuticals are increasingly being developed and studied. A whole different class now is antibody drug conjugates. This is, I often describe it as targeted chemotherapy. And what this does, you see that this figure is a different drug than the one I'm highlighting. This is a drug that has been that may end up FDA approved for non-small cell lung cancer this year. It's not being developed in small cell. This is another drug that's very similar, the DS7300, that is you can put in place for DS1062, and the figure is still the same. But what happens is it binds to the receptor B7H3, gets pulled into the tumor cells, and releases the chemotherapy inside the cell. That chemotherapy has its effect on the cell and kills the cell, and then the chemo spills into the surrounding area. And this chemo is membrane permeable, meaning it can cross into other cells in the area. So even if not every cell has this B7H3 receptor, that chemo can then still cross into those cells and have the same effect on those other cancer cells. So I used a bit more of the time than I intended, but I absolutely welcome any questions or comments, and I thank you for your attention. I think the sound is muted. I don't know if anyone is saying something.
Do we have any questions?
Ah. If no questions, can I get any comments?
Wait. There is a question, and I'm really glad that you can't see me, because it doesn't really have anything to do specifically with your talk, but it kind of does a little bit. So we have NIBs and we have MABs. Do MABs, are they consistently naming hierarchy of immunotherapies, or how does that work? Damn.
Sorry, you're saying are MABs a form
Yeah,
of...
so pick a drug name ending with NIB, pick a drug name ending with MAB. Is there any consistent naming of using MAB as the suffix when it comes to immunotherapies?
So MAB essentially stands for monoclonal antibody. And so that MAB is an immunotherapy. I'm trying to think of any outlier scenario that might not be. And off the top of my head, I can't think of any drugs that just incidentally have MAB. So atezolizumab, durvalumab, pembrolizumab, nivolumab, these are monoclonal antibodies. So these are immunotherapies.
Hi, Jacob. This is Christine Lovely.
Hello.
How are you?
Wonderful. It's great to hear your
We
voice.
wish you were here. It's great to hear your voice, and thank you so much for an awesome presentation. You have done so much awesome work in the area of lung cancer screening as well, and that hasn't come up yet today. And I was wondering if you could comment on screening for small cell and some of the challenges.
Oh, I am so grateful for that question because frankly, lung screening is our greatest opportunity at treating and curing lung cancer. Any non-small cell, small cell. Now, one of the challenges with small cell is that small cell grows more rapidly, but there's a misconception out there that somehow screening is not effective for small cell lung cancer, and that's simply not true. It's just that small cell lung cancer tends to grow more rapidly, so we're very likely to catch non-small cell lung cancer in an early stage where we're more likely to be able to cure it. We're more likely to catch that early stage in non-small cell lung cancer because in many cases, a non-small cell nodule may take a couple years to get to the point where it spreads somewhere beyond the chest. That's not true of everybody, but it's a much higher numbers in non-small cell lung cancer. Whereas with small cell, from the time people get their yearly scan to the next yearly scan, it's still very possible for a small cell to develop and spread beyond the chest. That often happens in less than a year. And so we diagnose limited stage small cell where we'd still treat with curative intent, with chemo and radiation typically, although surgery is a possibility, in about half of the patients that get small cell lung cancer that's screen detected. If screen detected small cell lung cancer, about half of the people have limited stage. So it is important. So maybe I'll just briefly explain that lung screening is getting a low dose CT scan once a year. Low dose is that it is a very limited amount of radiation. There's no IV, there's no contrast or dye injected. It's just lay down on a table for 2 minutes and get a CAT scan and you're done. And it's that simple. Once a year. We've showed significant reduction, significant improvement in lung cancer mortality on a scale that I'd say if lung screening happened by the current guidelines, we would save more lives or we'd save almost as many lives as if we cured breast cancer. It is that big a deal. And of course, we want to cure breast cancer too. And I don't mean to, compare different tumors, but it's that big a deal. And less than 10% of people who qualify for lung screening are being offered lung screening by their healthcare systems and primary care doctors. And there are a lot of reasons for that, but it's truly a failure of the healthcare system to our public. And so as Dr. Lovely's pointing out, I do a lot of work in trying to advance and help healthcare systems develop lung screening programs so that we can diagnose these lung cancers earlier and cure more people. So for everyone in the audience, if you know anybody that is age 50 or older who smoked, I'd say smoked at all. There is a calculation you can do, but just smoked at all, and the last cigarette was within the last 15 years, that person likely qualifies for lung screening. And I'd really urge them to go and get checked and to ask their doctor about it. There's a website by the American Lung Association called savedbythescan.org. And so you can go on there and fill out the questions and get more information about that as well and see who qualifies. It's savedbythescan.org. And I'd say, even if the last cigarette was more than 15 years ago, I'd still really bring that up and ask the doctor. That's one of those that I don't believe that should be in there. So ask your doctor about that.
Thank you, doctor. And we've got another question, and I've got one online when you're done, Jim.
Okay. When I was diagnosed with stage 4, I was told that I can no longer donate blood. Hopefully I understood that. But it sounds like what you're saying is, I can use my own blood as an active treatment for my immune system.
Sorry, he has a hard time talking. So he's asking, when he got diagnosed with stage 4 lung cancer, he was told he could no longer donate blood, like to the Red Cross. However, it sounds like you're saying that he could use his own blood to put back in his body as an,
Oh, no. I think I understand where the question comes from.
Yeah.
No, I was using that. If you've experienced donating blood, then you just know what it's like when that blood comes out. But what I was describing is something called CAR T, and this is a trial where we take patients' blood out, we pull off the immune cells and give you the rest of your blood back. That moment in the chair when you're connected, the blood comes down a tube, we spin it to separate out the cells, pull off the immune cells for the processing I described, and then that all goes right back. The rest of the blood goes right back in your body through the tube. That trial is around what we do for the immune cells to help create that immune response that I described.
Dr. Sands, we've got somebody from your fan club who sent us a comment online. This is from Hillary Fortin. I just wanted to thank you, Dr. Sands, for the ongoing incredible care you give to the patients. My mom was sorry, I don't have my glasses on, was a patient of yours who passed away 5 months ago, and trying to blow it up, but I'm afraid I might lose the thing. We had 2 wonderful years with our family, thanks to your great care. I'm so excited to see the advancements that are still being made, and I hope to help others with the knowledge I have gained throughout my mom's journey. So thank you, Dr. Sands.
Thank you, Hillary, for that.
Dr.
And,
Sen, did you have a quick minute? Oh, I'm sorry. Oh, that's okay. Thanks.
Hillary's mom always made me laugh. Hillary too. I laugh thinking about you and your mom because it brings me such joy, and it saddened me so much to lose her, but the memory of her still makes me smile.
Hi, Jacob. This is Triparna.
Hello.
Wonderful presentation as always. Hi. So my question is, with the new tarlatamab and the ADCs that are currently showing promising data, how do you see the first line changing? What do you think if these are approved? How would the first line and the second line change? And what are your concerns as a clinician about what that visit for a patient would look like once you have these ADCs and BiTEs in the clinic?
So, that's an exciting question to think about because this represents real advances that we're going to see. And again, it's, we can't, we're not going to slow down until it's everybody that's cured, essentially. But the fact that we're seeing stepping forward, that's exciting to see. I anticipate tarlatamab to be FDA approved. I'm assuming that would be FDA approved in the third line. I think the question is going to be whether or not to use it in the second line for some people. Right now in the first line is the chemo immunotherapy I described. There are ongoing trials. Will the addition of lurbinectedin matter in the first line setting? If that increases the number of people that have those long-term responses to treatment, well, that changes the second line picture too, because then you're using lurbinectedin in that first line maintenance rather than in the second line. The antibody drug conjugates, these are still so early. So although there's discussion about where that would fit in, I think we can probably discuss that again at next year's conference too. I don't anticipate anything substantially changing the first line setting between this conference and next year's, but looking the years ahead and saying, okay, what's going to happen? Is another kind of immunotherapy in the first line going to lead to that tail of the curve raising up? I think the big question is, how do we get the tail of the curve to the median? Meaning, how do we get those people that I'm saying might actually be cured? How do we get that up to the point on the curve where it's more than 50% of the people that are getting the drug that are having that kind of long-term benefit. In the short run, with tarlatamab approval, I expect that to be third line. Do you give it in second line? Maybe sometimes. The first line setting, I don't anticipate really being altered in the next year. But there are other things I haven't even talked about, such as EZH1/2 inhibition and things like that, or LSD1 inhibitors. These types of things might actually make the cells more susceptible to the immunotherapy at a scale that we haven't yet seen. And so in the next 5 to 10 years, what does this look like? When I finished fellowship, and at this point, this is more than 10 years ago now, but when I finished fellowship, I did not think we would see the cure of cancer in my lifetime. I was optimistic we'd see a lot of steps forward. But from what I've seen, even in the first 5 years out of fellowship, and with the involvement of these immunotherapies, then to see people that realistically, I believe, are cured of their metastatic disease, and to see that happen for somebody makes it now seem possible to happen for a whole lot more. And it's just a matter of where those unlocks are. So I've maybe wandered my way around saying that in the next year, I don't expect a drastic change to the standard of care other than the incorporation of tarlatamab as I've described, and that's probably approved in the third line, but maybe sometimes used in the second line. In 5 years, what will this look like? I'm optimistic that there will be something in that first line setting, and what will that be is harder to describe. And I'm even more optimistic about some of the stuff that's currently just beginning some testing and where it's been promising in the lab that I'm very hopeful will pan out to even higher percentages of these very long-term responses.
Hi, Dr. Sands. I'd like to bring this back to screening. I was a longtime heavy smoker, but even my oncologist said, when I said, I know I did this to myself, he said, no, you don't know that. He said, no, I don't know that. But in terms of screening, if what we're told is true, that only 10 to 15% of smokers get lung cancer, why is smoking part of the screening protocol, and will that ever change? Oh, I don't.
So it's an important question. First.
Know me, do I always sound like that?
Oh, sorry, what was that?
She was saying she doesn't want to sound angry. She was apologizing to the group.
Oh. Well, I didn't think you sounded angry. I thought you just sounded like you're talking into a microphone. But, so first of all, smoking does dramatically increase the likelihood of getting lung cancer. That being said, if there was one thing that I could somehow take away from a lot of people that I see, is it's this retrospective would've, could've, should've. Many people started smoking back when their doctors were smoking in the infusion rooms. I mean, the fact that we now look back and somehow be like, oh, this person shouldn't have smoked. I mean, as I said, the doctors were smoking as they're walking through the infusion room. Even if you didn't smoke, you were exposed to it from doctors. And so society did not really decide that this shouldn't happen until, it's been some decades now, but many people with small cell lung cancer started smoking back before then. But even so, when I was a kid, I remember smoking being like a cool thing and kids still doing so. And when you're young, you have a different perspective on things. And so the challenge here is, how do we live our lives with no regrets of the past? So did smoking increase your chances of this? Dramatically so. But that doesn't mean that now thinking back to when you started smoking and judging yourself on that is not only not helpful, but not even fair to yourself. But to more answer your question, we see lung cancer develop in people that never smoked. Certainly, that's usually non-small cell lung cancer, not as much small cell. That being said, I have a 38-year-old right now who never smoked, who has small cell lung cancer. And in those cases, it's really important to get DNA testing of the cancer because there are sometimes alterations to that. There are changes to the DNA where we can target it with a pill. In her case, she's a rare case where her tumor has that. But also related to that, more for non-small cell lung cancer, in populations that are at higher risk of getting some of these non-smoking related targeted DNA changes, lung screening studies have shown benefit from lung screening in those populations. But, maybe to speak of it another way, and I'm just kind of thinking this off the top of my head, but breast cancer happens in men too, but screening for breast cancer doesn't happen in men, even though there are men that develop breast cancer. And it has to do with, on a population level, what is the likelihood of developing that cancer, and doing screening studies in the populations that have the higher risk for it. So the smoking history does make for a higher risk, and therefore the lung screening really has shown clear benefit. Where that line is the question. Related to my prior comment, I feel strongly that we should not have a restriction on when someone quit smoking, because we know that even if someone quit 20 years ago, their risk of getting a lung cancer is still higher than in someone that never smoked. But what is that cutoff, and what is the population that we should screen is very much an ongoing area of attention. For lung screening, there's a risk model called the PLCO that is also discussed and studied. And from that modeling, we can say that, in these individuals, there's such and such a percent risk of developing lung cancer. A personal family history where mother or father got lung cancer, for example, increases the likelihood of somebody having a lung cancer. And so these types of risk factors, to then have a percent level, like a percent chance, and where we then draw that line of who we're going to screen, this is an area of great ongoing attention.
Thank you, Dr. Sands. I'm Ling Fan from Jazz Pharmaceutical. Thank you for the wonderful presentation. I want to go back to the lung cancer screening, and then hopefully more patients are going to be caught at earlier stage, such as limited stage. My question regarding is, if a patient, unfortunately we know, like patient with limited stage, sometimes the cancer come back. I just wondering, once the patient the cancer come back from limited stage, what's the next workup? How do we determine the stage of cancer, and how do we determine which treatment is the best for the patients? Thank you.
Yeah, very important question. So in someone who's had chemo and radiation, or had surgery and then chemo, everyone with small cell, even if it's really small, ends up getting chemotherapy because it can spread beyond the lung more quickly than what we see in non-small cell lung cancer, for example. So somebody has that treatment with curative intent, but then has something show up again that looks like it could be recurrence. It could be the cancer. We say coming back, or the cancer came back. It's not really the right terminology, because if the cancer is showing up again, that just means it was never gone. It was just too small for us to see on a CAT scan, but then it grew to where we can see it again. And so we say came back, but it wasn't gone. Generally speaking, I would get a biopsy in anybody where it looks like that happened, to verify that in fact it is small cell lung cancer and not something else. And the majority of people it is, but every once in a while there's some new cancer that ends up being something different, and just want to make sure that that's not the scenario. So I'd get a biopsy. If it was something just that showed up just within the chest, especially in someone who had a surgery and then got chemotherapy, if that showed up in a lymph node in the middle of the chest, then I'd consider radiating that. So if it's close to the initial area and can be radiated, that's something I'd consider. At the same time, even if it was a distant spot, but it's one spot, then I would likely also radiate that and then continue to monitor. And I have some individuals where they had a spot show up in their brain and then that was radiated, and we've monitored them ongoing now without anything else showing up. I had one patient where showed up in the kidney, and so we ended up ablating that, meaning that interventional radiology went in with a probe or like a needle that then stuck into that, and they were able to then kill the cells in that area. And she monitored her for, I think it was 2.5 years before there was something else that showed up. So had I been giving her chemotherapy over 2.5 years, it probably wouldn't have helped her any more than having monitored her. That being said, once it started growing and she had multiple sites of disease, then we're talking about next line therapy. And so then I gave her lurbinectedin as her second line treatment. No, I'm sorry. Actually, in her, she had just a couple spots and it was small volume. She had never gotten immunotherapy. And so I started her on immunotherapy with just that single agent, so just pembrolizumab, because as I showed you in that one curve, in the majority of patients that doesn't work, but when it works, can work for a very long time. And so with low volume, then I do that. If it's multiple sites where we really need to get some kind of response, then I'd start lurbinectedin as my next line treatment. Because that's going to work everywhere, and there's a higher likelihood that that's going to work than the immunotherapy by itself. But if the immunotherapy works, it can work for years, and as I've showed, some people are actually cured of this incurable diagnosis. And so that is that's kind of the general thoughts.
Thank you so much for your time today. I know we have several questions still left on the floor, but we are running out of time. And I know that you are also busy, Dr. Sands. Actually, the next speaker ran to the restroom, so I had one question, but it has already been taken. I'm sorry. Let me run very quickly.
Oh, okay. Good evening, Dr. Sands. My name is Vicki, and I do not have a question, so I'll give you a little break. But I do thank you for advocating for lung cancer screening. And it hits various communities. And me, myself, of course, I have private insurance, and my doctor, my primary, advocates for lung screening cancer. Not only for smokers, non-smokers. So my pledge is to follow you and also to advocate in my retirement years now for lung cancer screening, because we hear so much about breast cancer screening and your doctors will scream at you, you haven't had it, you haven't had it. But like myself, my doctor gave me an order for lung cancer screening a year before I even took the test. And it came up positive. But we caught it early. No radiation, no chemo, just a lot of follow-up and a lot of nerve pain medication. So I do thank you for just mentioning that, because you do not find a lot of physicians, they just hit the problem, solve the problem, but not looking back to see how we can stop the problem. So I thank you.
Thank you for that comment.